everyone, and welcome to the August 2025 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Mike Rickles from the University of Pennsylvania.
And I'm Alice Cheng from the University of Toronto, and we are your co-hosts for this podcast series.
Welcome to August, everyone. This year is certainly flying by quickly, and Alice, I'm sure you must have some fun facts about August that you'd like to share with everyone.
Absolutely. Do I ever? I have some doozies this month, so I hope everyone is ready. For my first one, did you know that in a non-leap year, there is no other month that begins on the same day of the week as August? This year, for example, August started on a Friday. And if you go looking at your calendar, which you're all doing right now, you'll see that no other month in 2025 will start on a Friday. How neat is that? I feel like from this point forward, even if you learn nothing else from this episode, it would have been worth your while to have listened.
Well, that uniqueness fits with the meaning of August, at least according to Merriam-Webster, of being marked by majestic dignity or grandeur.
Oh, wow, Mike. So now you're looking for fun facts. I'm liking this. I did not know this about August. In terms of other fun facts, so August 5th is National Underwear Day in the United States. Yes, you heard me right. National Underwear Day. My suggestion is if you're going to Google it, don't do that at work. August 11th is Mountain Day in Japan, which is a national holiday to create opportunities to get familiar with mountains and appreciate blessings from mountains, which is very wholesome and very spiritual. In contrast to that, August 16th is National Rum Day, which creates opportunities to get familiar with rum and appreciate its blessings.
Well, I think I'm still stuck at underwear, Alice, so I'm not really sure how to respond, but tell us, what does this have to do with diabetes?
It's got absolutely nothing to do with diabetes, Mike, but hopefully it's put a smile on your face, which is the best way to get your brain ready to learn.
All right. So with that, let's launch into the August episode of Diabetes Care on Air, in which we'll be interviewing authors of a feature article from the August issue and run through our popular rapid exchange segment, where we'll each pick 3 articles of particular interest to us.
So let's go. One of the feature articles from the August 2025 issue of Diabetes Care is a Perspectives in Care entitled Kidney Disease, the Forgotten Legacy of Type 1 Diabetes. I am joined now by 2 of the authors, Professors Merlin Thomas and Mark Cooper from Monash University in Melbourne, Australia. Thank you so much for agreeing to be part of this podcast, and congratulations to you and your colleagues on this featured article.
Thank you very much, Dr. Cheng. It's a great pleasure to be involved in this podcast with Merlin.
Thank you for having me on your podcast. That's great.
So this is an important review on the topic of kidney disease in those living with type 1 diabetes. So I guess the first question is, why is this an important topic and why now?
Well, we know that kidney disease is a major problem in diabetes. Most recently, we've all been talking about kidney disease in type 2 diabetes, but we've forgotten that type 1 diabetes is also very commonly associated with kidney disease and remains one of, if not the major complication determining the lifespan, the morbidity and the mortality of the type 1 diabetic population.
So how has the natural history of kidney disease in type 1 diabetes changed in the past 40 years? And in some ways, has the success of type 1 diabetes treatment led to more CKD in type 1 diabetes? Merlin, can you help us with that?
Well, thanks for your question. I think it's really important to know that the current therapy of type 1 diabetes has been hugely effective. The lowering of glucose and blood pressure and RAS blockade has changed CKD in type 1 diabetes. It used to be over a third of patients with type 1 diabetes developed persistent proteinuria and then had an inevitable progression to kidney failure or death, probably within a decade. Today, that rapid course only occurs in maybe up to 4% of individuals. But that doesn't mean that CKD has gone away. It just means that it's slowed down. And with the longer life expectancy of adults with type 1 diabetes, due to the cardioprotective and other kinds of things that we do, we are finding that as they live long enough, almost all individuals with type 1 diabetes will develop kidney disease. And it may be that in the future, the natural history, without new intervention, is going to be that almost everyone will develop renal failure with type 1 diabetes, as has been seen in the Pittsburgh cohort.
It's an interesting concept, eh? Our very success is now bringing back to life, I guess, our focus on CKD in type 1 diabetes. So, in the type 2 diabetes and CKD space, we now have 6 pillars of treatment, right? We've got glucose control, blood pressure control, RAS blockade with ACE inhibitors or ARBs, SGLT2 inhibitors, nonsteroidal MRA, and GLP-1 receptor agonists. And what's amazing is only 3 of which were actually there a decade ago, or established, I should say. But in type 1 diabetes, the story is different, as you've alluded to. So now let's walk through each of these, and please tell us about the evidence, or lack thereof, for each of these in the type 1 diabetes space. So let's start with what we know to be true, right? Glucose control matters, right, Mark?
Yes, there's no question that the early studies, first of all, epidemiologically showed that the level of glucose is reflected just by glucose measurements, and later hemoglobin A1C clearly were closely associated with the development of kidney disease. This was followed by some early studies with the earliest types of aggressive glucose control, and they did show reductions in microalbuminuria and modest but significant effects in reducing diabetic kidney disease.
Now, what about blood pressure control and RAS blockade? So surely there must be good evidence for these in type 1 diabetes. Merlin?
Well, blood pressure control actually was one of the first things that we showed, even before good glucose control, that could reduce macroalbuminuria and accelerated kidney function decline in type 1 diabetes. And so one real success story of the latter part of the 20th century was aggressive blood pressure lowering and reducing those fast progressors. But now we don't have as many fast progressors, and now we have much better levels of blood pressure control. The evidence for blood pressure lowering is a little bit more controversial in patients with CKD. For example, the trials of more aggressive lowering, for example, to aiming for a target of less than 120, both millimeters of mercury systolic, both in patients with type 2 diabetes and more overall in patients with CKD, the rate of kidney function decline is not significantly slowed. There may be less macroalbuminuria, but they're still losing kidney function. And we have no really good blood pressure lowering trials in patients with type 1 diabetes outside of those done in the 1980s, when the world was very different. The iPhone was different. There was no mobile phones. There were no computers. We were suffering from a huge rise in proteinuric patients, but we don't have them anymore. So the utility of blood pressure lowering hasn't been lost, but has been diminished by a long-term goal of kidney protection, which we can't achieve simply by blood pressure control.
Interesting. I hadn't really thought of it that way, but you're absolutely right. The world is different, and those studies are pretty old. So the question is there value in this age? So how about aldosterone antagonism then with MRA or other agents? Mark?
So I think that's been transformational in type 2 diabetes, where particularly finerenone and some of the other drugs of a similar class, and now even the aldosterone synthase inhibitors are coming. This will be an area, particularly in type 2 diabetes, which is clearly renoprotective. But the data in type 1 diabetes are still very limited. There are some small studies with spironolactone, which had the issues of hyperkalemia, but were shown to reduce albuminuria in people with type 1 diabetes. But we are fortunate that with the very good results in type 2 diabetes, studies are now in progress in type 1 diabetes. And we will hear later this year on early results from one of those studies known as FINE-1, which involves finerenone in people with type 1 diabetes. And based on studies in type 2 diabetes, the basic science, we're pretty optimistic that we will see some added advantage, but that is something we need to learn. And this could be one of the first new pillars for the management of renal disease in type 1 diabetes.
Definitely exciting. It's cautious optimism. At least that's how I feel. But I think more optimism than cautious. But still, it's cautious optimism. So, Merlin, let's talk about SGLT2 inhibitors, right? I mean, SGLT2 inhibitors have emerged really as foundational therapies in type 2 diabetes and or CKD and or heart failure. So, how about in type 1 diabetes in the context of chronic kidney disease?
You're absolutely right. How about type 1 diabetes? It's not that type 1 diabetes isn't associated with CKD, isn't associated with heart failure, isn't associated with premature mortality. It's got all of those things that an SGLT2 inhibitor should work on and work on very well over the long term. So there's every good reason that it should work in the setting. The problem is that we simply haven't studied it. And although the trials have focused on CKD and cardiovascular risk and diabetes, we haven't got the data in patients with type 1 diabetes to know that those benefits really do occur, but more particularly that these agents are safe in this setting. We know that a lot of physicians are desperate to use an agent that slows kidney function decline, that prevents fluid overload and heart failure, that all the manifold things that an SGLT2 inhibitor does in their really sick CKD patients with type 1 diabetes. But the problem is that using an SGLT2 inhibitor, someone with type 1 diabetes, increases their risk of ketoacidosis, which in someone with type 1 diabetes can be deadly in a matter of hours. It can be so sudden and so aggressive that people confuse it with an acute abdomen or an acute illness. So we still don't know the safety versus the risk, and that really needs to be matched by large-scale clinical trials or the development of some kind of mitigation. And I know that a number of groups are trying to work on ways of harnessing the benefits of SGLT2 inhibitors in patients with type 1 diabetes by trying mitigation strategies, whether that's continuous monitoring for ketones, some other ketosuppressive kind of therapy, or combination therapies with other agents that have that kind of effect. So the future really is bright to move these very powerful agents into type 1 diabetes, but questions still remain about safety before it can be widely used or indeed indicated for patients with type 1 diabetes.
Yeah, you're absolutely right, Merlin. I mean, if you talk to 5 different endocrinologists and ask whether they use SGLT inhibition in their patients living with type 1, you'll get 5 different answers along the spectrum from hard no to hard yes. And it's everybody's sort of all along there.
But they'd all say, I wish I could. They'd all want to, but some of them would go, but I can't, and some of them will, but I have to. And that's the kind of challenge we find ourselves in at the moment.
Absolutely. Absolutely. And then what about GLP-1 receptor agonists? So GLP-1 receptor agonists have an established role now in type 2 diabetes and CKD. So the question is, what is its role in type 1 diabetes? And then also, Mark, if you could address double diabetes. Double diabetes is something that you discuss within the paper. Can you also explain to the audience what in the world is that?
Well, of course, these people have type 1 diabetes, but type 2 diabetes is pretty common as well. And many of these people will have probably undiagnosed type 2 diabetes as well, which would be difficult to diagnose in someone already on insulin with type 1 diabetes. Furthermore, the way we treat type 1 diabetes with insulin, which we're giving subcutaneously and not through the portal vein, means that these people have to be exposed to hyperinsulinemia to control their glucose. So that could also be promoting, not just from a genetic point of view, but also from a exogenous form, they could be developing insulin resistance. So we need treatments that can address insulin resistance even in the type 1 diabetic population, which historically we considered insulin sensitive, insulin deficient subjects. So fortunately, here we have a class of drugs, the GLP-1 agonists. They're ideal for people with obesity or type 2 diabetes. And many people with type 1 diabetes will also have obesity or may have a predisposition to type 2 diabetes. So this could be an ideal drug to give these people to further improve their metabolic status. Furthermore, we've got such exciting results with GLP-1 agonists, particularly in the type 2 diabetic population, on renal disease. We're now seeing this in the obese population, and we also see a reduction in cardiovascular endpoints, particularly atherosclerosis-related events, which are also occurring in an increased manner in the type 1 diabetic population. So GLP-1 agonists are now being prescribed to all people with type 2 diabetes, obese people, and should be considered in the type 1 diabetic population. But we don't have very good data. We do know that they're only very modest at reducing hemoglobin A1C in this population, but we know that they have non-glycemic related benefits on the kidney and heart, problems that the type 1 diabetic population face. And so in the article, we list at least 6 ongoing studies that are studying GLP-1 agonists, usually semaglutide, but there are indeed studies now with tirzepatide, the dual GLP-1 GIP agonist, that are exploring different contexts in the type 1 diabetic population in terms of renoprotection. And hopefully within the next few years, we will have very convincing data emphasizing the renoprotective role of these agents. It also includes what's called the remodel type 1 study, where they're going to also look, as they're looking and about to announce in the type 2 diabetic population, how they believe these agents might work in the kidney, which remains a mystery since there are so few GLP-1 receptors in the kidney, yet we're seeing very good results even in the absence of significant glucose or lowering or weight loss. So this is a very exciting area. We've got these people with double diabetes. We've got people with obesity. We know they're at risk of renal and cardiovascular disease. So this would be an ideal population to validate the end organ protective effects, particularly on the kidney, of these agents.
So lots to watch out for. So finally, Merlin, what do you want to see in the future? And what is your call to action to all of us?
I think that the most important call to action is that all patients with type 1 diabetes are at risk for developing impaired kidney function if they live long enough. And therefore, kidney protection should be considered foundational for all people, everyone with type 1 diabetes, because everyone with type 1 diabetes, if they live long enough, they'll result on the cumulative effects of their glucose exposure on their kidneys and will have kidney damage. Glucose control, blood pressure control, RAS blockade, that can get rid of macroalbuminuria, but is not enough to slow kidney function decline over time. And therefore, we need to do something different. And foundational kidney protection should be the norm in the future for all people with type 1 diabetes. At least it would be if we had something to do about it. And at the moment, the interventions that we've got, SGLT2 inhibitors, GLP-1, aldosterone antagonists, they are renoprotective agents, but they're unproven in type 1 diabetes, and there's potentially serious risks for their use in that setting. And so our real call to action is that we need now to start not leaving type 1 diabetes out of our trials by saying, oh, they're too hard or they're not the same. We need to incorporate more people with type 1 diabetes into these studies to examine evidence for heterogeneity and clear evidence of safety so that we can start bringing these really powerful agents to the help of our many patients with type 1 diabetes at risk of kidney failure.
Excellent call to action. And I think one thing that I have been doing a lot more, I'd say in the past year or so, is instead of feeling like I'm doing my patients a service by using these therapies, frankly, off label, because I want to, as you had alluded to in the past, Merlin, is I'm actively seeking out whether there are clinical trials happening in my area where I'm able to refer those individuals, as opposed to me just starting it off label, but actually looking and finding out. And I encourage all of our listeners to do the same. Wherever it is that you're working, just find out if there's a site near you that's conducting some of these studies that have been mentioned. And if so, send your patients over so that we can actually collect those data that we require. So a huge thank you to you, Professor Merlin Thomas, Professor Mark Cooper, for spending time with us today and reminding us of the forgotten legacy of kidney disease in type 1 diabetes. It is high time that we catch up the evidence for organ-protecting therapies in those who live with type 1 diabetes, and it sounds like the future is exciting with a lot of data being collected. And I encourage our listeners to read the full article in the August issue of Diabetes Care.
Let's move on now to the rapid exchange segment, where Alice and I will discuss articles we found of particular interest this month. Alice, why don't you get us started?
Well, my first pick is by Professor Claire Meek from the University of Leicester and colleagues on behalf of the Concept Collaborative Group. Using data from Concept, which was a randomized trial of real-time continuous glucose monitoring versus SMBG in pregnant women with type 1 diabetes, this group had previously shown that A1C, time in range, time above range, and average CGM glucose were robustly associated with clinical outcomes. The aim of the study published this month was to determine if a 6-day glucose management index, or GMI, derived from CGM, is a reliable approximation of A1C and can improve prediction of relevant perinatal outcomes in women with T1D in pregnancy. Analyzing the data from 220 women, they were able to determine that GMI was not an accurate replacement for A1C. The GMI commonly showed biases of plus or minus 0.5% compared to A1C. In addition, the GMI did not offer additional predictive capability for suboptimal perinatal outcomes over that of time in range, time above range, CGM average glucose, or A1C. Therefore, the authors concluded that clinicians should use A1C, time in range, time above range, and mean CGM glucose to inform management decisions with pregnant women living with type 1 diabetes.
That is very interesting, Alice, and for me raises the question of validity for the equation that's used to calculate GMI from CGM average glucose to estimate A1C in pregnancy, and suggesting that further validation of that relationship in pregnant women is really needed. My first pick relates CGM metrics to stimulated C-peptide measures in youth with recent onset type 1 diabetes. Dr. Anna Naiman from Indiana University School of Medicine in Indianapolis and colleagues from the Clever Study Group analyzed data from 103 children enrolled in their trial investigating closed loop and verapamil in new onset type 1 diabetes, and compared CGM metrics with mixed meal tolerance test stimulated C-peptide over 52 weeks following diagnosis. A combination of CGM time in range, time below range, and coefficient variation predicted peak C-peptide being greater than or equal to 0.2 nanomolar per liter with a sensitivity of 68% and specificity of 75%. The authors note that this relationship isn't strong enough to replace measurement of C-peptide in clinical trials, but I do feel argues that this serves as additional validation of C-peptide as an endpoint that has important influence on glycemic control, especially when using CGM measures that incorporate the dynamic range of glycemia that is often missed when assessing by A1C alone.
And CGM being much more accessible and easier to do, or I guess get, in people compared to the mixed meal tolerance test stimulated C-peptide, I think it'd still be interesting to see in clinical practice if that's something that we could potentially use in the future. So very cool. Thank you, Mike. My next pick also falls into the category of diabetes in pregnancy. In clinical practice, women living with type 1 diabetes often ask whether or not it is safe for her to breastfeed when her blood glucose levels are elevated. To feed or not to feed? That is the question. Dr. Lois Donovan and colleagues from the University of Calgary in Alberta, Canada, sought to describe the relationship between maternal glucose, as measured by CGM, breast milk composition, and volume of breast milk ingested by the infants, which they determined by pre- and post-breastfeeding infant weights. Mid-feed breast milk samples were collected from 11 breastfeeding mothers with type 1 diabetes wearing CGM, providing a total of 47 breast milk samples that were included in the analysis. Direct relationships were found between maternal CGM glucose and breast milk glucose and fructose. However, there was no relationship between maternal CGM glucose and breast milk lactose, protein, or free fatty acids, which are major contributors to caloric content of breast milk. The volume of breast milk consumed also did not correlate with maternal glucose. They also looked at breast milk leptin, which is known to correlate with maternal BMI. There was no relationship between maternal CGM glucose and breast milk leptin levels. The authors conclude that this study provides some initial information to reassure breastfeeding women with type 1 diabetes that their glucose at or before breastfeeding should not influence their decision to breastfeed their infant or not. Further study, of course, is required to determine if differences in breast milk composition can influence offspring growth or future metabolic risk.
Those are very interesting data, Allison. With the direct relationship between maternal CGM glucose and breast milk glucose and fructose, CGM glucose during lactation might be a useful surrogate for breast milk composition in future studies of outcomes in offspring. Now, with all the attention on CGM measures of glycemic control, my next pick provides new data for our old friend, hemoglobin A1C, in individuals with diabetic kidney disease. Dr. Dia Kofod and colleagues from Copenhagen University Hospital in Denmark undertook a nationwide registry-based cohort study of adults with diabetes that included over 27,000 with severe chronic kidney disease, defined by an estimated glomerular filtration rate, or EGFR, less than 30 milliliters per minute per 1.73 meters squared. Also included over 80,000 individuals with mild to moderate chronic kidney disease, defined by an EGFR of 30 to 59, and over 80,000 with no to mild chronic kidney disease that was defined by an EGFR greater than or equal to 60. For individuals with severe chronic kidney disease, the 1-year risk for experiencing a major cardiovascular disease event, or MACE, increased significantly with a hemoglobin A1C level of 7.2 or higher when compared to those individuals with a hemoglobin A1C between 6.3 and 6.6% who had the lowest risk. So these results argue against the suggestion that glycemic control targets for individuals with severe diabetic kidney disease may be less strict than for those with preserved renal function.
That's a very interesting study that you just described there, Mike. And as you were talking, I was reflecting on how we'd always been taught that as people's kidney function declined and they got more sick, that maybe we can relax their A1C levels. And it's really nice to be reminded that no, we should still be working hard to try to achieve appropriate glycemic control, because the most common cause of death in that group is, of course, going to be cardiovascular in nature. And I would encourage our listeners and remind them of an excellent interview that I had when I had the opportunity to speak with Dr. Clara Klein, who had done a review article on this very topic about diabetes management in those with kidney disease. So I encourage people to go back and listen to that one. My final pick is an important one to provide reassurance regarding thyroid tumors and GLP-1 receptor agonists. Dr. Daniel Morales from University of Dundee and colleagues from the United States, Germany, Spain, and the United Kingdom conducted an active comparator new user cohort study in patients identified from electronic health records and claims data from these countries. This study is part of the large-scale evidence generation and evaluation across a network of databases for type 2 diabetes mellitus initiative, which is also known as Legend T2DM, which I personally think is a fantastic acronym. So kudos to whoever came up with that. So this study that I'm going to describe is part of Legend T2DM. Their aim is to generate reliable evidence on the effects of second-line glucose-lowering agents using observational healthcare data by conducting a series of comparative observational studies aimed at minimizing bias and increasing reproducibility. In this analysis, they aim to determine whether people with type 2 diabetes initiating GLP-1 receptor agonists have a differential risk of incident thyroid tumors compared with other glucose-lowering agents. Over 460,000 users of GLP-1 receptor agonists, 717,000 users of SGLT2 inhibitors, 2 million users of DPP4 inhibitors, and 1.1 million users of sulfonylureas were included. Thyroid tumor incidence ranged from 0.88 to 1.03 per 1,000 person years in the GLP-1 receptor agonist cohorts. Exposure to GLP-1 receptor agonists was not associated with an increased risk of thyroid tumors compared with the other glucose-lowering agents. Analysis using thyroid malignancy and including a 1-year lag period produced similar conclusions. These data contrast those from a nested case control study from France, also published in Diabetes Care in 2023, that has been criticized for its study design and potential for residual unmeasured confounding. These data from Dr. Morales and colleagues in this month's issue of Diabetes Care are more reassuring and consistent with other analyses published in 2024 from Korea. Ongoing post-approval safety studies and routine pharmacovigilance monitoring will provide further information over time.
Those are very important and reassuring data. And it seems that as long as GLP-1 receptor agonist therapy is tolerated in the short term, then the long-term benefits so far seem to outweigh any risks as far as cancer is concerned. For my final pick, I'm going to return to C-peptide measurement in recent onset type 1 diabetes. And here, Dr. Michelle So and colleagues from the University of Melbourne evaluated simple clinical measures of beta cell function. So rather than from a mixed meal tolerance test, these are fasting measures of C-peptide collected from the BANDIT randomized clinical trial of baricitinib in recent onset type 1 diabetes. They looked at a quantitative response score for this C-peptide difference from baseline to 1 year after intervention, together with fasting C-peptide as well as a modeled C-peptide, and found these most reliably differentiated placebo from baricitinib treated participants. And when they combined additional data from the randomized clinical trials of rituximab, abatacept, and antithymocyte globulin at recent onset, when looking at 12 weeks post-intervention at beta-2 score, which is derived from measures of fasting glucose, fasting C-peptide, hemoglobin A1C, and insulin dose, they found this was the optimal measure for predicting a positive quantitative response score at a year following intervention. So these fasting, and not fasting so much for A1C, but an insulin dose, but these simple clinical measures may provide a less burdensome primary outcome to collect for future trials of disease-modifying therapy for type 1 diabetes, and may even be used as the 12-week measure was predictive of outcomes a year later to assess early treatment response and adaptive trial designs or potentially influence clinical practice.
And I'm always a fan of data when it's looking at things that we can easily get and measure. Because it's one thing when we read these clinical trials, and of course they need to measure sophisticated biomarkers, et cetera. But when it comes out in the real world, we need stuff that we can actually get our hands on and potentially measure in our patients. So I love these kind of analyses. So that was really fantastic. Thank you. Thank you, Mike. Well, everyone, this brings us to the end of the August 2025 episode of Diabetes Care on Air. Thank you to Professors Merlin Thomas and Mark Cooper for sharing their expertise with us.
And a big thank you to you, our listeners, for tuning in. Remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe and get notifications about new episodes of this podcast. Thank you for listening.